All right. In the interest of time, we'll get kicking here. Thank you all for coming this late morning for our talk on hostility in the hospital and the challenge of caring for combative patients. And we'd like to thank the SAEM Ethics Committee for their sponsorship. My name is Kevin McGurk. I'm from the Medical College of Wisconsin. I'm hoping this microphone on the table works so that my co-panelists can introduce themselves.
Hi there. I'm Ed Durant from Kaiser Central Valley, California.
I'm Ashley Winfield from Cook County Health.
Hi, I'm Sunshine Mavens, also from Cook County Health.
All right. We have no conflicts to disclose. Some objectives for our talk today. We aim to identify and discuss some of the ethical principles at the root of caring for combative patients in the emergency department. We'll review some of the legal and the regulatory elements that are pertinent to these encounters. And lastly, we're going to discuss some practical strategies that can be applied for individuals and departments to safely deliver care for combative and hostile patients. And then, time permitting, we are hoping to have some open opportunity for audience participation. I'll include this QR at the end as well, but a lot of the resources that we reference or utilized can be found at a website linked from this code. I'll leave that up for a second. All right, just to get us into a clinical frame of mind, I want to start with a case, something that I think will be easy for all of you to relate to. I want for you to imagine that a patient in his mid-30s presents to your emergency department. He comes up to the triage desk. He appears to be in no apparent distress. He has non-labored breathing and a stable gait. When he presents to the desk and is asked what brought him to the hospital, he says he wants to speak to a doctor. When asked why, he declines to comment. And unfortunately, the situation escalates from there. The patient becomes more and more aggressive and hostile and ultimately begins threatening triage and hospital staff. Other patients waiting in the waiting room are visibly anxious and they're nervous with this gentleman around, and so security is called. It's easy to imagine a case like this. Perhaps some of you had something like this recently. I want for you to think for a moment, what would you do in this sort of situation? You have someone who is seemingly in no apparent distress, but hostile and agitated. And we'll circle back to this case in a bit. So if you read the news and you keep an eye out for articles on emergency department or hospital violence, you'll likely find stories like this one from Minnesota about increasing violence or workplace injuries. You might find something like it in Pennsylvania or New Jersey, Colorado, Florida. Clearly illustrating this isn't a local problem and this isn't a state problem. This is a national issue. And indeed, the numbers bear that out. Many of you may have seen this particular chart before. It's often used. This is from the U.S. Bureau of Labor Statistics, looking at episodes of workplace violence and injuries from 2011 until 2018. And just at a glance, you'll see two trends that are pretty apparent. One, these incidents are increasing as more and more folks are having workplace violence episodes, leading them to missed days of work. And two, the bulk of these episodes are happening in healthcare facilities. Indeed, more of these are happening in healthcare facilities than all other professional industries combined. And even more troubling, the trend seems to be getting worse. Anecdotally, the pandemic felt a little bit like a tipping point, and that a lot of this behavior became more and more pronounced, more and more aggressive, and there are statistics to support that. The American Hospital Association reported that there's been a 44% increase in physical violence against healthcare workers since the start of the pandemic, and a 68% increase in verbal abuse.
So as Dr. McGurk mentioned, unfortunately, we have experienced a lot of workplace violence. There was a survey that was done by ASAP where they were saying in 2022 about 85 EM physicians believe that the rate of workplace violence has actually increased over the past 5 years. And then again in 2024, they did another survey saying about 91% of EM physicians report that they have either had workplace violence against themselves or they have seen one of their colleagues been a victim of workplace violence. So I wasn't just take a second and survey the crowd. Can you raise your hand if you've witnessed, let's say, verbal workplace violence? Either you're, okay, that was almost everybody. I was gonna say either yourself or a colleague, but I myself, again, have definitely witnessed that. Raise your hand if you've witnessed or experienced any physical workplace violence. That is more people than I would have expected to raise their hands. And unfortunately, that's a very unfortunate a circumstance that almost everybody in this room has either witnessed or personally experienced workplace violence. Do you guys think that it has been worsening over the past 5 years? I see a lot of heads nodding. And so that shows the importance of having discussions about these kinds of things. What are some solutions that we can have moving forward? How to de-escalate? What are some approaches and techniques that we can use?
I apologize for the clunkiness. We envisioned a table where we would seamlessly be integrated going back and forth, so apologies for that. We want to acknowledge that there are absolutely pre-hospital considerations here too. These same sorts of issues that we're experiencing in hospitals and emergency departments are true for our EMS colleagues as well. They exist in a difficult space, one that sits sort of at the nexus of healthcare and law enforcement. But the particulars of how EMS is confronting this and how they might best address this issue is beyond the purview of this talk. We did, however, include an NAMS policy statement in the references. So before we sort of really sink our teeth in, I want to take a moment to think about how we're defining our terms. Now, ultimately, our goal here is primarily to focus on non-organic etiologies for aberrant behavior. Of course, if a patient is combative or hostile, aggressive, because they have meningitis or their blood sugar is 10, those are emergent processes that demand our attention, and sometimes we're going to expect some neurocognitive issues that come along with. But that really isn't what we're trying to talk about for this particular talk. Instead, I'd like for you to imagine the sorts of patients who maybe present to your emergency department 3 times a week. Do all of you have a patient like that? Yeah, or maybe even 3 times a day. And these folks in particular who often have a pattern of hostile or aggressive behavior or prior violence against healthcare providers, these are the kinds of folks that we're trying to direct most of our attention to. But when we do so, I want for us to be deliberate in how we use terms and to whom we apply them. So what does it mean for a patient to be hostile? What does it mean for a patient to be aggressive? What does it mean for a patient to be violent? And who are we going to label with those words? There's absolutely evidence to suggest that there is a significant socioeconomic and racial and ethnic disparity in how and when we apply these terms, and that often carries with it significant clinical consequences. And so I want for us to be mindful about how we're thinking about this in the mental models that we're constructing as we work our way through this talk. And this isn't uniform, so I want to take a moment just for your own consideration to think about, for each of you, when does a patient's behavior cross that threshold, that imaginary dividing line that states now you need to pursue something like chemical or physical restraints? When does a patient need to be sedated? What does it take for you to reach that level? When do they need to be forcibly removed from the hospital? What sort of triggers are necessary to reach that point? And lastly, when are you going to seek something like arrest by law enforcement or more law enforcement involvement in your department? And how and when do you decide that you're going to escalate?
So now that we've discussed the background and scope of violence in the emergency department, let's talk a little bit about some of the legal aspects that we have to navigate as doctors and healthcare professionals. I'll start with a case that highlights some of the potential pitfalls of labeling a patient's behavior as violent or combative and escalating too quickly to interventions like physical or chemical restraints or even law enforcement involvement. The key is that these interventions should be a last resort rather than the default, and that medical conditions need to be thoroughly evaluated before taking these actions. So consider the case of Barbara Dawson, who presented to the ED with shortness of breath and was subsequently discharged. When she refused to leave, she was arrested for disorderly conduct and trespassing. And unfortunately, she went into cardiac arrest in the police car in the parking lot of the hospital and died due to a massive pulmonary embolism. This brings us to a critical aspect of emergency medicine, which is the Emergency Medical Treatment and Labor Act, or EMTALA. Some of the unique challenges of applying EMTALA in the ED with combative or non-compliant patients can create significant legal and ethical dilemmas for us as doctors and for healthcare providers. So to give you some background, EMTALA was passed in 1986. It was designed to prevent patient dumping and to ensure that anyone presenting to an emergency department would receive an appropriate medical screening examination and stabilizing treatment regardless of their ability to pay. These provisions essentially created what is a federal right to emergency care. Some of the key provisions of EMTALA include the requirement for a medical screening examination, or MSC, to determine if emergency medical condition exists, providing stabilizing treatment, and strict transfer restrictions to prevent inappropriate transfers and patient dumping. Under EMTALA, Medicare participating hospitals with emergency departments are all mandated to provide a medical screening exam to all patients who come to the ED to determine whether an emergency medical condition exists. And it's important to note that the definition of emergency medical condition under EMTALA is broad. It includes both medical and psychiatric conditions, including patients who have symptoms of severe agitation and who may be combative. They still must receive an appropriate medical screening exam. So once an emergency medical condition is identified, EMTALA requires the hospitals to provide stabilizing treatment and arrange for any appropriate transfers. EMTALA does not have any specific provisions for combative or violent patients, but it still mandates that the hospitals provide an exam and treatment to those patients. Hospitals can take safety measures and should, such as involving security or law enforcement when appropriate, but they still have to uphold the patient's right to emergency medical care. Here are some other notable cases. In all of these cases, the hospitals were found liable for EMTALA violations. Case one, which is based on a real case, we'll revisit later. There was another and these are just a couple of many. There was another case in Iowa of a patient who presented to the ED saying that his mind was disturbed. He ended up eloping from the hospital in single-degree weather wearing paper scrubs, and he was found 300 feet away from the hospital dead from hypothermia. In another case, there was a 41-year-old with a history of depression who presented to a hospital in Missouri after a suicide attempt by overdose. His blood alcohol level was 288, and the hospital policy at that time was that patients with a blood alcohol level of over 100 were discharged to law enforcement, so the patient went to jail that night, returned the next day after he was released from jail with another suicide attempt, and was admitted to the ICU. So these cases highlight some of the challenges in providing appropriate medical care and some of the potentially catastrophic outcomes when managing combative or agitated patients, especially those in the midst of a psychiatric emergency. Next, we'll discuss the ethical challenges of providing care in these challenging cases, and Dr. Winfield will discuss how we can balance these ethical principles in our practice.
All right, so now that we've had a little bit of a touch on some of the legal ramifications, we'll talk briefly about some of the ethics, specifically medical ethics, which is, ethics is very broad and very complicated. So we're talking specifically about sort of some of the basics of medical ethics. So if you look at the ASAP Code of Ethics, obviously this slide has a lot of words on it, but I've bolded some of them. But if you think about it, there's so many conflicting things even within these words, right? So we have an obligation to protect ourselves, staff, and patients from violence. And oftentimes, I don't know if you guys have been called, we have a behavioral health area, and I'm called to the back because there's an agitated or aggressive or violent or whatever word you want to use patient, and everybody wants me to restrain, but I'm also balancing the needs of the patient who hasn't had time to be de-escalated or talked to, and then I'm also balancing like how angry are they going to get? Are they going to punch my nurse in the face? And so you kind of find yourself already with the very first sentence in a very difficult place because you're balancing the needs of everyone and the safety of everyone in the room. Hospitals have a duty to have adequate trained security personnel. This looks different in different places. I know for us, we have actual Chicago police officers who are then trained to work in the facility, and they carry guns, which we'll talk a little bit sort of about some of the trauma-informed principles that go into some of this. But, you know, for certain populations, that's automatically not safe if I walk in and there's a policeman in the front door with a gun. So we're already balancing that. It also means that there may be some loss of autonomy for some of these patients requiring restraint, which we'll get into a little bit more. And so just sort of recognizing even within sort of the guidelines that we're giving, it's just very difficult because you're balancing the needs of everyone. So when we're talking about the bill, okay, well, all right. When we're talking about some of the basic 4 principles of ethics or medical ethics, rather, you have the 2 that we know first, right? Do good, beneficence, and non-maleficence, not non-malfeasance, which I want to say all the time. I guess they're both similar-ish, but beneficence and non-maleficence. So that goes back to our original Hippocratic oath, do no harm and to help people. And then over time, we added autonomy, sort of respecting the patient's rights as an individual, respecting their agency, and then into principles of justice, which you can sometimes link with equity, which is more about just sort of making sure, one, everybody has the same access to care, and we're also balancing the needs of the greater population as a whole. And I would argue that justice, we just didn't left that one out in many, many different ways, just as evidenced by sort of the disparities in certain things we have in medicine, but again, not the point of today. So these are sort of the primary ones that we use to guide ourselves. And you can often see in instances where these things will contradict one another. So there may be times that you may infringe upon a patient's autonomy in order to provide beneficence. There may be times that you may cause harm. Maybe you're doing a procedure, maybe it's a chest tube, maybe it's a line that's temporary harm for the overall benefit of the patient. And so all of these things work together, but again, you're balancing them as a part of your care. And then the issue we start to have, though, is what is an unacceptable level of risk, right? So we come into work, and obviously things exist on a gradient. You come in, you may expect to be cursed out. I don't know, maybe you don't. I get cursed out regularly. It's like every day, man. Something about my face, I guess. It's probably me, but that's okay. So we saw this a lot during COVID, right? Like, what was an acceptable risk? We were coming in and we were wearing trash bags. We were reusing N95s until they were porous. It was just not a good time. And nursing literature is actually much better about describing what's an acceptable level of risk, probably because they're more so at the bedside and more likely to sort of take on some of the physical brunt of it. But the idea is that we have to kind of figure out for us, what's acceptable? Everything exists along a gradient, and obviously that gradient doesn't go up to death. That's not what we want to do. And so we need to figure out what we can tolerate within the realm of doing our professional duties. And Dr. McGurk touched on this already, but again, and then we'll talk about this a bit with sort of the ideas of trauma-informed principles, but being very careful with labels. We're just going to hit on it one more time. I'm not going to spend as much time as McGurk did, but I've been called aggressive in a text message. I don't even have tone. I was just answering you. I was trying to eat a sandwich at the same time. I was definitely not being angry. I was just trying to answer you quickly. And so, you know, sometimes we will add these words to people. And I don't know about your systems, but we have a few people who are regular offenders who have been known to punch staff in the face. And so we've been trying to get a system, especially with like the turnover of contract nurses every few months. You guys may not have that problem, but they don't know our regulars. They don't know the guy that's likely to punch you in the face. And so we started putting labels in the chart, which then biases you against people. And it's a whole thing that maybe we can discuss at some point today, but just be very mindful of how you're ascribing those and if you have a pattern of who you're giving those to. So we'll move on.
All right, so we're going to return to that case at the very beginning. So as a reminder, this is our mid-30s gentleman who came in, wouldn't tell the triage folks what his complaint was, became increasingly hostile, and was ultimately escorted out by security. I'd like for you to imagine now that that patient returned 10 or 15 minutes later. Would you do something different? Would you start with a blank slate? Would you tell him, get back on out the door? What if he didn't come back in, but instead his significant other did? And she said, look, I know he's being a bit of a turkey, but someone should really take a look at him. Would that change how you approach this case? Well, as Dr. Durant mentioned, this is adopted from a real case, and unfortunately, there was a bad outcome. The patient's girlfriend returned to the desk and said, look, please, someone look him over. I don't know what's wrong, but something is wrong. And she was told he's been escorted out. He's not welcome to come back across those doors. They went to another hospital where, unfortunately, he expired that day. Now, details are a little bit spartan because this came from a Health and Human Services settlement after an EMTALA violation, so there's relatively scant details. But it highlights some of the same challenges that Dr. Durant mentioned, where we're trying to balance caring for sometimes hostile and aggressive patients while also being beholden to a federal mandate to provide at least a medical screening exam. And in this case, it didn't happen, and the hospital paid for it. I think maybe if we can use the microphone. How do you feel about that, Dr. Mavens? I'm wider than I used to be, so 2 at the podium is a little dicey. So I'd like now to get a resident perspective, which Dr. Mavens is going to offer us. And if you could, I'd like for you to share with our attendees here what sort of education or training you're receiving as a resident for dealing with these sorts of cases.
Yeah. So being in emergency medicine, one of the first things that we were taught in orientation, intern year, is how to help with de-escalating a patient. That kind of set the tone. that is something that we had to know since intern year. There are many different ways that we have learned it. One, formal lecture teaching, where they say, use verbal de-escalation, before you use medication, and then restraints. But then on top of that, we have the luxury of having a wonderful simulation center as well. And so we've also had different simulation cases where we've had people act as the agitated patient, having to decipher, is this something like a thyroid storm, or is this actually like an agitated patient? Is this alcohol withdrawal? So helping to know the differences between the different circumstances. And then when you do have an agitated patient, what are things that you can say? What are things you can do, from the tone of your voice to the position of you in the room, to maybe there shouldn't be a lot of people crowding around the patient at once. Those are things that can escalate the situation even more. And then obviously life experience as well, having my own patients who have escalated as well. When you're trying to balance not only the nursing staff, when you're trying to protect yourself, but also have the patient's best interests at heart, what are things and tools that I have learned? Personally, I always try to verbally de-escalate before anything else. I know a lot of people sometimes may not feel comfortable with that at first, but I have had luck a lot of the times in doing so, being able to relate to the patient, saying, I know that you are feeling these certain this is how you're feeling, acknowledging how they are feeling, using a certain tone of voice, sometimes that, standing over a patient, maybe clearing the room out from all the people's security and all that there if I feel comfortable. But the one question we wanted to ask is, I know there are many other residents in the room too. Have there been things during your training in the past that you felt like has helped you most with trying to learn how to successfully de-escalate an escalating situation?
Just so we have a sense of who's in the room, are there any residents here? Can you all raise your hand? I recognize a few of you guys.
There's a lot of them.
A bunch. Fabulous. And then faculty? Okay. Yeah, about half and half. So in preparing this talk, we spoke a decent amount about how, from the faculty standpoint, often, at least I and Dr. Winfield, Dr. Durant, try to take steps to protect our residents and our students from some of these patients. If you see someone has a behavior flag that they've been aggressive or violent or inappropriate sexual behavior, often we'll say, look, that's not a good case for you. For our residents, we're trying to protect them, or our students perhaps even more so. But then we need to balance that with also giving our trainees some experience at dealing with patients who sometimes have these problematic and aberrant behaviors. And so we're hoping to maybe get a sense from the room, if anyone feels comfortable taking a mic, I'll deliver it like Vanna White, how you're balancing that in your personal experiences.
Hi, I was looking around because I am glad but disappointed at how many people are crowded into this room and all concerned about the same topic. So I'm from Boston Medical Center, and again, we are a safety net hospital, and we used to have the practice of shielding our residents, and anybody who was the patient you described, we would expedite their care into the trauma room, and we would have a focused team of just a nurse, attending, and public safety at the sideline. Can you hear better? So we would expedite care to the trauma room, and we would have a limited team to interact with that patient, both for trauma-informed care, not to have them feel surrounded, and also to be able to control the surrounding a little bit. But then we were doing our residents a disservice. And so we started to have our senior residents actually be the direct communicators, and they would practice verbal de-escalation. However, in the room, if anybody had a better rapport with the patient, we would trade off, and then there would be a single communicator. The attending, we run it kind of like a trauma case in that I'm gonna look at the computer, I'm informing the situation, I'm standing back. If there's a safety issue, I might pull a lever and say, okay, we're done, and make that decision. I try to give my senior resident the autonomy to do that, though.
You look shy.
Thanks. No, I'm so excited that you guys are talking about this and bringing more attention to it. So thank you. I'm Patrick from Okersey from University of Utah, and I'm a faculty there. And I've seen a pivot probably post-COVID, and there's a big focus on including the residents in this. And I'm proud of one of my colleagues, Zach Drapkin, who runs a course now dedicated to, they call it now conflict management as opposed to conflict resolution, because your goal is to manage the conflict. And it covers conflict from patient provider interactions to multiple providers, consultant interactions, all kinds of conflicts that we face on a regular basis. So I think there's a lot of attention being put into trying to include the residents into this now, which is awesome.
It's total. All right.
All right. Thank you both for your insights. So we're going to talk just a little bit about some strategies, and as we recognize this is a real and national problem, what steps can we take, beyond, mastering hand-to-hand combat? So we're going to talk just a little bit about some de-escalation techniques, and more importantly, Dr. Mabins is going to talk with us about applying trauma-informed care and principles. We're going to talk a little bit about some of the new Joint Commission standards and how those are impacting hospitals or should be impacting hospitals. And then we're going to review an ASAP workplace safety checklist. I do just want to add a note, though, before we talk about stuff like de-escalation techniques or trauma-informed care, that we also wanted to be careful not to blame the victim, so to speak. And I'm sure lots of you could think of stories like this one. A nurse comes to you upset because someone punched, bit, threw urine on them, and they went to their manager or leadership and were told, well, what could you have done to have prevented this situation, right? And certainly taking steps to prevent these situations from escalating are important, and the onus is on us to make sure that we take those steps. But the onus isn't only on us, and there are absolutely system and hospital level issues that need to be addressed. I mean, an ounce of prevention is worth a pound of cure, but we're not the only people involved in this. And so with that, I'm going to turn over to Dr. Mabins to talk with us about trauma-informed care.
Does anyone in this room, I hope there are a lot of people, heard the term trauma-informed care? Great. Okay, good. Because this is going to be a brief summary and then transition in how this is appropriated in this talk. So trauma-informed care is the idea that, people experience trauma, or trauma being the 3 E's, events, experience, and effect. And everyone can experience a situation, and it can affect them differently, and they can experience that same event differently. And recognizing there are certain people who have had multiple traumatic experiences through their life, and knowing that that is the person that you're experiencing that day. The ACE studies I think we've all heard this at this point, but when people have experienced a lot of trauma in their life, it has increased their risk of certain mental health issues, physical health issues. And then recognizing when somebody is there in your emergency department, what state are they there with you? Are there certain triggers that are in that situation from past traumatic experiences that are causing them to escalate in that situation, that are causing them to be a little bit more agitated? Having that kind of scope of who your patient is really important. And so there are different things that we can do to try to decrease the amount of escalation up to a certain point. And so safety. Allowing there to be more of a safe space for that patient. So some people's triggers may be that they are now security cameras or that there's not security. Somebody may have a trigger seeing that there is a lot of security and that there are gun holsters. That might have them already in a hypervigilant state. Other things are transparency. When you're having communication with your patient, if they are knowing exactly what is happening in their care during their stay, that makes some people feel a lot more comfortable. If I know we're all busy when we're going through all the different patients that we have to see, and sometimes there's a long period of time between when you see a patient and when you can see them next, and they maybe get more agitated, like, what's been going on this whole time? I've been just sitting here for 5 hours, I have no idea. So sometimes providing that transparency allows, again, to prevent an escalating situation. Again, patient-centered care, allowing them to be have mutual decision-making, patient-centered decision-making, allowing them to have choices in their process. Of course, when it's life or death, we give those choices. But if there's something where they can have more of a say in their care, that can sometimes allow there to be less of a escalation in that process. Empowerment, allowing them to have voice, and also allowing the understanding of knowing like the cultural aspects, cultural, historical, and gender issues that can involve a situation. And I think with having all of these pillars and this mindset of trauma-informed care, a lot of times you can even prevent a escalated situation, an agitated patient, before even having to use verbal de-escalation. So these principles, using these on a day-to-day, a lot of times can mitigate these additional triggering or traumatic situations for our patients.
All right, so as was mentioned before, there are some changes being made at the national level, kind of impacting the landscape of hospitals, and one of them starts with the Joint Commission. Now, if you're like me, you probably historically have thought of the Joint Commission as the police that come through to yell at you for like Scotch tape on walls and coffee at workstations. Their purview is a tiny bit broader than that, and so they have adopted some additional things into what is necessary for hospital accreditation. And now, as of 2022, that includes components about what steps hospitals are taking to ensure a safe workplace environment. And so some of the components of these requirements, and just pause, am I the only one who is unfamiliar with these? Are all of you guys plugged in with the new Joint Commission? Yeah, this was news to me. So hospitals, as a requirement for Joint Commission accreditation, need to have in place policies and procedures to both prevent and respond to workplace violence. And there's a lot of components that go into this, and I don't want to belabor all of the words on this slide, and there's another to come, but there are references to this in the QR code at the end. But there needs to be in place a system for folks to be able to report incidents. There needs to be some sort of tracking and monitoring system, and the hospitals need to be taking steps to act upon this. There needs to be some sort of lever that can be pulled for follow-up on each of these. Perhaps just as importantly, there needs to be transparency in this process so they can collect data and generate a report, but it's not particularly useful if no one can access that report. And perhaps just as importantly, there should be some component for people to be able to make report anonymous concerns, and especially in places where people might fear some sort of personal or professional retribution if they come forward and report workplace violence incidents that happened. Now that applies at the hospital level, not the departmental level, but in response to these new Joint Commission standards for accreditation, ACEP actually came out with a checklist for recommendations on how emergency departments can make sure that they are in compliance with this same sort of spirit. And we're not going to walk through each of these individual components, but it hits on a lot of the same central elements, that you're taking steps to prevent as best as possible workplace violence. If indeed they happen, you're taking steps to log and chronicle them, that you have some sort of reporting mechanism, and again, one that can be anonymous, and that there's transparency throughout the process. There's also language that the department should be taking steps to address this stuff. So if you are demonstrating and documenting a problematic pattern, the onus is in part on the department to demonstrate what steps they are taking to help ensure staff safety and that they're going to prevent or alleviate some of these issues. And then how we can safely involve law enforcement, and that there is follow-up on the back end to make sure that all of this is being done appropriately. And again, another story that I suspect a lot of you could probably relate to, a hypothetical scenario, perhaps a agitated or aggressive patient punches one of your staff members, a tech, a nurse, a physician, and police are summoned and they say, don't worry, we'll take them off site, we'll escort them away from here. And that's as much as the law enforcement involvement is. That's where it sort of begins and ends. Have any of you all seen episodes like that? Yeah, and so the ASAP policy, this checklist is meant to ensure that there is some sort of departmental follow-through to make sure that that's not where it begins and ends, that we're taking sort of more substantial steps than that. Just a brief acknowledgement that there are other sort of legal and regulatory considerations at play here too. At the state level, there are lots of different states that have implemented or have proposed legislation to increase penalties if there are violent acts towards healthcare providers. There are some others that have passed or proposed laws to, quote, permit healthcare workplaces to exercise more force against violence, end quote. And I'm not a lawmaker, and so I don't want to get too lost in the weeds about what that could or could not mean. I'll reference back to the karate slide. But my reading of the tea leaves was more that this is an attempt to protect departments who might need to take steps like chemical or physical restraints and sedation from litigation by the patients, rather than encouraging us to like assault patients who are being hostile. But again, I'm not the lawmaker, so don't quote me on that. And then lastly, some have laws in the books allowing for healthcare facilities to establish their own independent police forces, which is its own can of worms. I'm going to just acknowledge that it is a can of worms, and we won't go more in depth than that. All right, and then lastly, there is an important role here for advocacy. This is a dynamic process. This is an ongoing issue. There are a lot of stakeholders involved who are trying to take steps to make sure that this situation gets better and not worse, and advocacy is an important component of that. There's a picture from a story back in March with multiple heads of different professional bodies, including ASAP and two large nursing organizations who were lobbying federal legislators to try to take national steps to address this ongoing crisis. All right.
So we're just going to have a little bit of a chat with the last few minutes we have left to kind of see what you guys are seeing. What are some of the things you may be doing at your institutions? I know for one of the things, I kind of like the regulatory bodies having something we can hold our institutions to, because very frequently we have events, especially we're a level 1 trauma center. Our staff members have to go outside and sometimes retrieve people, and they get caught in the middle of big family dramas, and we don't have a clear reporting system. It's like an angry email chain, and then everything kind of calms down, and then a few weeks later somebody else goes through the same thing, which when you're talking about trauma-informed principles, it's that we're just creating trauma on trauma in the workplace, which is somewhere we have a reasonable expectation of safety. Do any of you guys have a place or have a reporting system for these events where it's taken seriously by your institution? You do? Can you want to talk about it at all?
So great talk, and I also echo what you said. I thought the same thing when I saw all these people. I said, that speaks volumes about what an issue this is. So I'm Jacob Bartnick. I'm the medical director of St. Barnabas Hospital in the Bronx, Safety Net Hospital as well. We see a lot of workplace violence. I liked what you said about... Oh, sorry.
Yeah.
The point you made is very challenging to me, and the don't blame the victim. I don't know, one of you made that point. Yes, there are steps that need to be taken to prevent violence, but probably immediately after the event is not the time to talk about those with that
Correct.
person. So I've tried many things to try to dissuade, this is a topic that keeps me up at night, honestly. And we've created an ED workplace violence committee that reports to the hospital-wide workplace violence committee as required by Joint Commission. Honestly, at the first meeting, I had probably 30 residents show up. And by the third month, we are down to maybe 5 or less. So it's challenging to kind of keep that momentum going. So we tried that. We put metal detectors in our triage area. We had NYPD officer that we hired to be in our waiting room as well. I don't have much insight or any advice per se. We're seeing a ton of violence, and I think the point you made about labeling patients and the implicit bias that can happen in these situations is one that is also incredibly challenging.
Yeah, it scares me a little. It's like I appreciate it, but also it scares me a bit because it's like militarization of like our hospital police forces, and like we know who is disproportionately affected when that happens.
So I do want to share one success story that our hospital has had with this. So we implemented like an early psychiatric kind of intervention where we like treat agitation early with like oral medications. We use second generation antipsychotics with oral medications like Zydus medications. And then we have, a scale that's kind of nursing titrated so that our boarding patients can get agitation treated early. And then we recognize like physical restraints as like a high risk procedure that, not a never event, but one of these things that we should. And not only did we reduce our ER physical restraints from about 30 a month to down to 1 to 0 a month, but we also had that go across the entire institution. So even we have an inpatient psychiatric unit, and their numbers dropped by about 90% as well, just by doing like early treatment and recognizing that agitation needs to be treated early and not waiting until someone gets to the point where they're combative and flailing with their like when they start pacing in the hallways and start getting hyperverbal, like that's when we should be intervening and not necessarily doing that. But I do also have a question because I'm doing some advocacy on this. Some of our legislators are a little bit hesitant, at least at our state level. They were hesitant to make this a higher kind of crime and criminalized a little bit more. And the argument being is that like more criminal penalties isn't going to fix the problem. That's not really the way to kind of address this issue. And I have scars on me from being bitten by a patient, which are freely available on my Senate's testimony website if you want to go look at them. It'll save you the $9.99 from the other place you can get shirtless pictures of me. But I'm just kidding. But the question is that really and I was maybe a little angry. I don't know after that kind of incident, and I thought maybe that was the right answer. Was well, maybe if we make it a felony, you punch a police officer, you go to jail. You punch a firefighter, you go to jail. You punch a nurse, like what could the nurse have done better to make the situation, better, right? So it just is the disparity is a little bit frustrating. And again, I'm not sure that the criminal system is the right way to deal with it. I just didn't know if anyone had any other insights. And this particular lawmaker I'm talking about was like, show me some data that says that this prevents it, and I couldn't find any. And I don't know if anybody has any or has any other insights into that.
I would just add, and I agree with all of that. Two things. First is I hope you have written up, and if you haven't, that you will, about your
Nothing
success
expertise.
story, because that's something that you should absolutely disseminate, because that's fabulous. And regarding the harsher penalties, I mean, we're just trying to give you all a sense of what the legal landscape looks like, as opposed to really endorsing some of these takes. I would argue that the bigger issue is one of enforcement rather than the stiffness of penalties. Like you said, you punch a firefighter or postal worker on the street, you're going to go to jail. You punch Dr. Durant and you're going to get, I don't know, droperidol in a sandwich, right? And so it's not so much that the penalties aren't harsh enough and need to be made harsher, it's that they should be enforced in the first place.
I think
Would
part
be
of the
my
problem
take.
too is we don't even know at my institution, if someone gets up and spits in my face, it's not even clear to me what my options are. Staff don't even know in what ways they are protected, which is part of at least where I work, that's part of the problem. And then when we do go to our police force, they're like, oh, do you really want to do that? He's in the psych area. And I'm like, but he's aware, so it becomes difficult. And I think it relies on institutions to have clear policies. Okay.
MSU, HBC University of Grand Rapids. We're just in the last 3 months have had 3 residents physically assaulted pretty badly. And one of the things that came up in that was not necessarily harsher penalties, but can we press charges? And they said yes. so that made all of my residents say, nope, not doing that. I don't want them to know where I live. I don't want them to have any information on me. And so I think that that is a little bit of a deterrent too, because yes, if you were assaulted on the street, like that would also be the situation. But as a healthcare worker, like, you already know where I work, you're not gonna know where I live. And I know that my 3 residents that had it recently, we had a large issue with them, which is why I think we just talked very tiny. They're all having a hard time, like kind of bouncing back a little bit with feelings of anger or being nervous about being out some of the patients. We have a really busy ER, and we funnel all of our more acute cases to our resident mod, and it's really taking an effect on them. And so I kind of wonder how that affects you guys in training, and then also just like going forward, because now you need some trauma involved here.
Yeah, we didn't put him in this slide, but and we even really get to it, but we talked about it from the lens of like recognizing maybe trauma activation in the patient, but also us understanding how trauma shows up in ourselves is a big part of that, and being able to deal with it. And so I do a lot of work with myself, Dr. Brown before, I do trauma informed education with my residents, because if you understand it and how it's showing up in yourself, that's part of mitigating it and part of the process. And I think it makes it a whole lot easier. Like if I'm sitting in triage and the triage nurse is battling it out with the patient, which I see all the time, especially more so since COVID, I'm seeing 2 people who are super activated, and understanding that some of the patient agitation and aggression, and when I got Chris out today, is not me. I mean, it's not me usually, you know what I'm saying? That kind of helps me deal with that, but also it's on the understanding of faculty to recognize that, because I get a lot of faculty that are like, well, if you can't deal with it, it's for your resilience. Like, yeah, they just spit on you, but be tougher. I got spit on all the time. And so it's also faculty and us as leaders on shift who don't allow them to space the process and don't ask them if they're okay.
And just to build off that too, this slide, this isn't episodes of workplace violence. This is days of work missed. And so if we look at how many people are missing work, that's this. But this is a tiny fraction. This is the tip of the iceberg. For every 1 person who's missing work, there might be 100 who are punched or spit on or whatever else. There were a bunch of hands.
So I think it comes down to reporting. And you mentioned like you had no data. So we actually at BMC, we have a reporting system. You file an RL, the same as you would for any patient safety. There's an employee safety icon. And that can be, I tripped, I hit my head on a shelf, or I got physically assaulted. And there's a pull down menu and there's a descriptor. All of our workplace violence incidents get funneled to our workplace violence committee. We have a threat assessment team that looks through every public safety flag that goes in to try to identify patterns in patients that are our multi-visit patients who maybe are recurrently causing trauma to our staff. And any of those patients that have that, that's when we start to think about labels. Yeah. Because we don't want to put the label for a single incident if that person is in behavioral crisis. It's the pattern that's the problem. So those plans that get put in place may include security, may include early medication, may include identification of their triggers, because we don't want to just label them as a violent patient. We want to label them often as a person who has experienced significant trauma, is triggered by our public safety officer. Please have them stand outside. They engage better with a female male provider. You know, please do not touch them without permission. Like, we want to give you tools, and so we try to put that forward. But I would say that's where your data is. We track our patients who cause violence, and all of a sudden they don't show up. And oftentimes it's because they're incarcerated. And we leave their behavioral flag there because they need to have touches in the system ongoing for a year before we will make a decision to remove it. Because initially we were like, we don't want these flags in here forever. We want them to expire. But they might just expire because they've been arrested for 5 years, and then they come and they're the same person. And so I would say that's where you might be able to find data, is a lot of our patients are in and out of the incarcerated system. So we actually did a build out in Epic where there's a pop-up triggered for our highest safety risk patients, and it will like say what their key issues are. And everybody's key issue is a little bit different, right? Some people cause self-harm, some people cause harm to others, some people, you know, it depends. So every patient is unique and they're customizable. And then it links to a plan because, again, everybody's got different doses of stuff that they respond. Their psychiatrist will work with to inform that plan or based on historical data.
One more success story that I can't take any credit for, and another plug for trauma-informed care. The folks at Brigham and Women's Hospital just did a massive intervention where they trained everyone in trauma-informed care. The paper's called Code De-Escalation, and their results were pretty incredible. They saw a decrease in incidents of workplace violence, in addition to decreased restraint use. And then they also looked at the equity issue and found after their intervention that they were starting to close some of those gaps that they were seeing in disparities in restraint use. So yeah, trauma-informed care.
Okay.
Just to kind of, there was a point about the nuance of these patients that are combative, and I think that's really important to make. More so on the like prospective side, before they become combative or as they're becoming combative. You know, on the retrospective side, if somebody swings 90 people, you sort of don't care whether it's because they were drunk or because they were psychotic. But as patients are becoming combative or becoming violent, it's really important to understand the nuance of kind of dividing those into, I would say, 4 main buckets. One is like an intoxicated patient. One is a patient with like psychotic disease. One is patients who are like cognitively impaired, like dementia patients. And then the last one is just like so-called normal people who are maybe just frustrated with a long wait, being in pain, being scared about, you know, why they're sick and why they're not getting their testing done fast enough. So those are sort of like, the nuance of those 4 situations is very different. This is particularly for the residents in the room. But there's very different interventions for those 4 like situations. And just being familiar with your pharmacology for psychotic patients versus intoxicated patients. There's a point about sort of early intervention with pharmacology, like oral medications, trying to partner with patients in that regard. So understanding the pharmacology for intoxication versus psychosis versus dementia. And then in that bucket of so-called normal people who are just frustrated and in pain and scared about their illness, that's really where you can just like lean on your customer service skills and offering them like something to treat their pain, a warm blanket, a turkey sandwich, you know, that kind of stuff. But just the nuance of these different situations where patients are typically becoming combative, I think thinking about it in that way can be very helpful as these patients are arising and as you find yourself in these clinical scenarios.
I think we've exceeded our time, so thank you all for your time, and have a good afternoon.